Now, before we begin, there's a few things we need to go over. First off, the information presented in this program is intended for use by trained EMS providers. Also, due to variations in protocols and scope of practice among different states, departments, and agencies, this program may discuss or depict procedures, medications that are not acceptable in your daily use. If you see something in this presentation that varies from your agency's policy, always follow your department's protocols. Also, none of our authors or presenters of this program have any conflicts of interest or financial relationships they need to disclose. We do have documentation of this on file available in our office upon request. While we do our best to make sure that all the content we present is the most current available, participants are reminded that medicine is indeed a dynamic science and thus changes rapidly. So things may have changed since we've written or compiled this program. Please always follow the most up-to-date information available. In closing, if you have any questions about this or any of our other programs, please email us at info@valormed.net. Thank you very much and welcome to the program. Hi there, my name is Mike Sullivan. I'm one of the instructors at Valor Medical Services. I'd like to welcome you to ECG Interpretation 1. Now, this is the first in a series of several classes we'll be having on ECG interpretation. Quite frankly, the topic is so large it was very difficult for us to break it down into just one class or just one segment, so instead we're breaking it down into several segments. So this will be the first module. After this, we'll get into Module 2. Now, 2 is broken down into sinus rhythms, atrial and junctional rhythms, AV blocks, ventricular rhythms, ectopic complexes, and lastly, pace rhythms. Beyond that, we're actually going to be getting into ECG 3, where we'll get into multi-lead, with 12-lead, 15-lead, and other diagnostic rhythms. But let's start out with this class for now. We're going to talk about the primary parts and subparts of the cardiovascular system, the anatomy and what makes up the heart and the cardiovascular system. We'll talk about the role of each of these parts and subparts. We'll discuss and differentiate between ECG leads and electrodes. We'll differentiate between continuous and diagnostic ECGs and how they work. We'll get into the features of ECG paper, the actual paper that the tracings are printed on. We'll discuss and describe the relevant parts of the ECG complexes. We'll classify each of these parts of the ECG complex as either normal or abnormal. We'll identify what normal sinus rhythm is. By the end of this program, you'll know the criteria to identify something as normal sinus. Then in ECG Module 2, we'll start breaking down some of the different types of rhythms that we'll see out there. But first, let's get back to basics. The cardiovascular system is responsible for transporting oxygen and nutrients to all the body's systems and transporting waste products out of the cells to be removed from the body. It's made up of 3 primary functional parts, the first of which is the blood, then we have the blood vessels, and lastly the heart. Now when we break these down into smaller groups, we'll take the blood. The blood is made up of red blood cells, or also known as erythrocytes, and these are the big red boxcars, I always describe them as, that carry oxygen and nutrients to the cells. Think of these as what delivers the good stuff into the cells so actually the cells can keep on functioning. Also in the blood is we have white blood cells. These are also known as leukocytes. Now these leukocytes are there to fight infection. In the case of some type of pathogen or some type of invader or foreign body in the system, they detect it and they'll actually surround this object and they'll actually try to fight the infection or fight the pathogen, whether it be a bacteria, a fungus, or a virus, and actually designed to take it out of the body. Then we have our platelets. Now platelets are thrombocytes. They're designed to begin the clotting process and help control blood loss. Many times you'll describe platelets as small parts of cells that actually aggregate together and actually help form clots, and they're the beginning parts of clots as blood begins to clot when it's exposed to air. Lastly, we have plasma. Now plasma is a watery fluid. It transports much of the waste products back in the blood to get out of the body, and it makes up about 55% of the blood. This is what keeps the blood fluid and flowing well. Now, all this blood has to flow through something. We have the vessels. Now, the vessels are broken down into arteries. These carry blood away from the heart, typically under pressure. Every time the heart pumps, a pulsation is sent out through the arteries, and that's why when we check a pulse, say at the wrist, we're checking a radial pulse. If we're checking a pulse at the patient's neck, we're checking a pulse at the carotid artery. Veins, on the other hand, are carrying the blood flow back toward the heart. Now, they're not under as much pressure as the arteries are, and they're a continuous flow, typically of darker red deoxygenated blood. In between the arteries and the veins, we have something called capillaries. Now, capillaries are small, semi-permeable membrane, and they actually allow gas and nutrient waste exchange to occur. Think of these as almost the loading docks, where the blood gets to the capillary and it can offload the good stuff, the nutrients and the oxygen for the cells, and upload the waste and the carbon dioxide that needs to go back toward the heart and back toward the central circulation to be dealt with. These are your primary vessels. Lastly, we have the heart. Now, the heart is a four-chambered pump. It's typically located in the left-hand side of the chest and is roughly about the size of the patient's fist, maybe a little bit larger. Now, a variety of cells actually make up the heart, including myocardial cells, which are muscle cells, myo, and pacemaker cells. Now, these pacemaker cells enable the heart to generate electrical currents on its own. The heart is made up of these four chambers: the right atrium, where we have blood that comes in from the rest of the body, and this is all returning from the rest of the body into the heart. It then goes through the tricuspid valve into the right ventricle. Now, once it's in the right ventricle, it gets pumped over to the lungs by way of the pulmonary artery. The pulmonary artery, although it's going away from the heart and is under pressure, is the only artery in the body that has deoxygenated or low oxygen level blood. The reason is because it's on its way to the lungs to offload the carbon dioxide as an off gas and pick up a fresh load of oxygen. Then once it comes back from the lungs, it goes into the left atrium. Now as it enters the left atrium, it'll then get pumped from the left atrium down to the left ventricle. And as we look at the diagram there, the left ventricle is at the base of the heart, and it pumps it out to the rest of the body, the oxygenated blood. The left ventricle is actually what functions every time we feel a pulse anywhere in the body. It's because the left ventricle sent it there. Now, in addition to the chambers and the four parts of the heart and the different valves, the heart has an electrical system all its own. This electrical system is made up of three primary pacemakers. First is the SA node, or the sinoatrial node. This is the dominant pacemaker of the heart, and normally for an adult at rest, it will fire 60 to 100 beats per minute, or 60 to 100 impulses come out of the SA node per minute in the normal patient. Now, if for some reason that the SA node does not function, doesn't function properly, stops functioning, begins skipping beats, there's a backup, and that's the AV junction, or the atrioventricular junction. Now, this is the secondary pacemaker of the heart. It runs at about 40 to 60 beats per minute. Now, as you'll notice, that's less than the 60 to 100 we'd get from a normal SA node, but it still is enough to sustain life for a while. Now, if the SA node and the AV junction both give up, then we'll have the Purkinje fibers. This is the last backup pacemaker of the heart, and it's good for about 20 to 40 beats a minute usually. So typically we think of it with the three pacemakers, think of them almost as quarterbacks. We have the starting quarterback, the SA node. He may have a 60 to 100% passer rating. Great. But if he gets hurt or something happens or he goes down or he's not feeling well, we have a backup, and that backup will step into the game is our AV junction. And he's not as good as the starting quarterback, but he can still keep a 40 to 60 passer rating, so it's a little bit better. Okay, great. Now, if something happens and he goes down, well, then we may have the Purkinje fibers come in. and they've got about a 20 to 40% passer rating. Things are going to keep going, but just nowhere near as well as it would among the others. No offense to backup or second or third string quarterbacks, but let's face it, a 20 to 40 passer rating isn't going to give us the same end of game results as a 60 to 100 passer rating. So, okay, now that we've talked about these pacemakers, let's talk a little bit about how they actually work. At the top of the heart here, you'll see the SA node. That's marked in right here. As the impulse leaves the SA node, it causes the two atria to fire, and the impulse comes down to the AV junction, or the atrioventricular node. When it gets to that junction there's a brief pause, and then the impulse will travel down through the Purkinje fibers and cause the ventricles to fire. The top of the heart firing, when the atria fire, is the lub of the heart. Down here, we have the dub of the heart. So when we put it all together, there's our textbook, lub-dub, 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 as it works from top to bottom. Now, if for some reason the SA node does not function, the AV junction right here will be able to make the impulses again, not as quickly, not as effectively, but it will actually do enough to get the ventricles to fire, and partially the atria as well. If that's not making impulses, it will come all the way down to the Purkinje fibers here, and they will keep the ventricles firing at 20 to 40 beats a minute. However, there'll be no atrial kick and no atrial preload coming down to the ventricles. Therefore, again, while it will work, it will not work for long. So, since we know the heart runs on electrical impulses, let's get into what exactly is an ECG. An ECG, or an electrocardiogram, and you can call it an ECG or an EKG, the terms are used interchangeably, is a graphical representation of the electrical activity within the heart. It doesn't necessarily mean that the heart is having a pulse or is actually pumping. What it is saying is that that's what the electricity is doing, or the electrical impulses are doing. In order to monitor an ECG, we attach electrodes to the chest at specific locations to measure the electrical currents which are presented. It then prints off in a graphic format that we can look at. The graphic format is broken down into different leads. The lead is a representation of electrical activity between one or more electrodes. When we talk about the limb leads, it's between two electrodes. However, in some cases, it's only monitoring from one direction, in which case it's a unipolar lead. So let's look at some of the electrodes here. We'll start looking at the limb electrodes first. Now, the limb electrodes are typically colored white, black, and red. Sometimes they'll have a fourth one, which is either green or brown. The white goes to the right arm. The black goes to the left arm. The red goes to the left leg. And the green or brown remaining one goes to the right leg. You'll often hear providers say, white's on the right and smoke is over fire. If we look at it, you see on this, they have the electrodes labeled at the patient's wrists and at the patient's ankles. That's one configuration that can be done. Another one you may see in the field, especially in pre-hospital medicine, because it's a little bit more difficult sometimes to access different parts of a patient's anatomy. We may see the white electrode placed up on the right shoulder, the black electrode placed over on the left shoulder. The left leg electrode may be placed on the patient's abdomen above the waistline here, and the green or brown remaining lead goes here. Again, you'll hear white on the right, smoke over fire, which would be the black over red, and sometimes you'll hear about white over brown or green, which is either ground or grass, depending on how it's referred to. And this again gives the same general triangle as if they were on the distal extremities. In the pre-hospital environment, a lot of times you'll see the goal is to get an electrode picture that's equal distant all the way around. If you're going to put this electrode on the shoulder, you have to put this one there. You wouldn't want to put it down here. At the same token, if you're going to put this one on the shoulder, you're going to not want to put the other one down here. Again, building this, what we call Einthoven's triangle, will give us the best picture of what's going on with the patient's heart and the most reliable tracings. Now, once we've put the electrodes in place, the monitor will typically be able to monitor what we call the 3-lead, which will give us the limb leads of lead 1, lead 2, and lead 3. Now we'll go a little bit further here. Lead 1 monitors between the right arm and the left arm, going across the chest. Lead 2 monitors from the right arm down to the left leg, and lead 3 monitors from the left arm down to the left leg. Looking at it a little bit more in depth, here we have lead 1. Now the negative electrode for lead 1 is at the right arm. The positive electrode is at the left arm. So electricity moving from here to here will show in lead 1 as a upward or a positive deflection because it's moving toward the positive electrode. When we go into lead 2, we're actually looking between the right arm and the left leg. The right arm on the right is the negative electrode. A pulse coming this direction or an impulse traveling downwards, because it's moving toward the positive electrode, will result in a positive deflection on the lead 2 tracing. By that same token, an impulse moving from here backwards would result in a negative deflection as it's moving toward the negative electrode. So, since this most closely resembles the line that the electrical impulse follows in the heart, it gives us the best view, and we'll be focusing a lot on lead 2 in this and a lot of our upcoming videos. Now, we can also use lead 3. In lead 3, we're looking from the left arm toward the left leg. The left arm would be the negative electrode. The left leg would be the positive electrode. An impulse moving from here down would be positive in nature because it's moving toward the positive electrode. If it was going the other way, it would be negative or a downward deflection on the tracing. Now, these are your primary limb leads. However, we can go far beyond limb leads. We have supplemental leads as well. Some of the supplemental leads are what we call the augmented leads, AVR, AVL, and AVF. These are a combination or a mix of the limb leads and sort of a halfway between point, so to speak. In addition, we have our precordial leads. These are not bipolar leads like the augmented leads or the limb leads are. They're actually unipolar leads. Now, the precordial leads go across the front of the chest, and that would be where we have V1, V2, V3, 4, 5, and 6, and potentially posterior leads as well. And we'll get more into the augmented and the precordial leads in part 3. These come in a lot more when we're dealing with 12 lead, 15 lead, and other multi-lead configurations. For now, let's just focus on basic lead 1, 2, and 3 limb lead monitoring. Now, there are 2 types of ECG monitoring we can do. There's continuous monitoring. Continuous monitoring is monitoring the electrical activity, the rate and regularity of the heartbeat. You can use it to evaluate effects of some medications and treatments that may speed up or slow down the heart rate. It may or may not correlate with pulses. As we said, this is only the electrical activity, and what we'll do is we'll frequently monitor the patient's pulse physically at the wrist by checking a pulse and make sure it corresponds to the complexes that we see on the strip. Now, we frequently will monitor in the pre-hospital environment at lead 2. The reason we monitor lead 2, like I said before, it most closely resembles the path of electricity through the heart. Another type of ECG we can get into, and we'll talk more in section 3 about it, is the snapshot or multi-lead. Now this, instead of being a long-term ECG, is a snapshot or a single shot that takes a brief 2.5-second look at several different leads. And this display will print each of these leads. Now this is ideal when you're trying to look for ischemia or injury or infarction, as it gives you 12 different views of the heart. We'll actually talk about 12 and 15 lead more in section 3. These are typically used in a patient with possible acute coronary syndrome, or if you're trying to do something more at a diagnostic level. than just simply monitoring the patient's heart rate. If you look at the printout here, you see it still has lead 1, 2, and 3, but each one of these covers about a 2.5-second burst, and then it will change over and it will show us the augmented leads. And after 2.5 seconds of those, it will show us lead V1, 2, and 3. Run those for 2.5 seconds, and then it will run leads 4, 5, and 6 over here for again about 2.5 seconds. That would be a 12-lead EKG printout. In addition to these on top, down on the bottom it will show us a full lead 2 strip, a full V1 or V5. These can be set to different leads, so if you wanted to look at a longer lead 2 strip, you have it all the way down here on the bottom, which again you'll see as we go through. Sometimes it's a lot easier to look at a longer strip, especially if you're dealing with a very irregular rate, and so you want to get more of a look at it than just a small strip up here. Again, we'll get further into these into part 3 of the presentation when we get into multi-leads. For now, we're going to stay at the basics. Now, as you notice, all these ECGs are printed out on graph paper, and this graph paper is actually specially designed to monitor out time. The paper moves by the stylus at a set speed. That speed is usually 25 millimeters per second. When we say 25 millimeters per second, that actually allows us to use the graph paper to mark out different intervals. So now let's look a little bit closer at this ECG paper and how it works. The mark between the two large lines is 1 second, or 25 millimeters. Now this 25 millimeter segment here is broken down into 5 smaller boxes. Each one of these is 2/10 of a second, or 1/5 of a second. Now, with this being 1/5 of a second, or 21/100ths, or 2/10, either way we want to express it, that would be 0.20 seconds. Each one of the littler boxes, the small boxes here, would be 0.04 seconds. Those would be the smallest boxes broken all the way down. So now we can actually use this to monitor the time that it takes an impulse to go between various parts of the heart. So let's recap it. Time is a horizontal axis. The time between two of the large hash marks is 1 second, or 25 millimeters. The 5 small boxes represent 1/5 of a second, 0.2, or 5 millimeters. And when we subdivide those down, each of the tiniest boxes is 0.04 seconds, or 1 millimeter. And we use that to measure the length and duration of different impulses. But what are the impulses called? Well, we'll start with the first upward deflection is known as the P wave. That's the one right here. And the P wave is the sign of the atria actually contracting. It's an upward deflection typically, and that upward deflection means it's electricity moving toward the positive electrode. As you recall from our lead 2 strip, that would be moving from the upper left-hand side of the heart, the SA node, coming down toward the AV junction. Because it's going down toward the positive electrode, it's an upward deflection. Then we'll have a pause here as the impulse gets together and prepares the trip through the ventricles. The first downward deflection here is the Q wave. That's the negative deflection in the QRS, and that's the impulse being conducted through the interventricular septum. Now the Q wave should be less than 0.04 seconds, or 1 small box in width, and it should be less than 1/3 the height of the total QRS complex. As that electrical impulse moves on, we have our QRS complex. It starts here, and it goes all the way through the interventricular septum, and then we have a large upward deflection. That upward deflection would be the trip of the impulse down through the center of the interventricular septum, and this here downward impulse will be the impulse going out through the Purkinje fibers. It will eventually return to the J point, where there will be a brief pause and then a T wave. The T wave is the ventricles repolarizing. This should be predominantly the same direction as the QRS complex, and it should be smaller than the QRS complex. Now, we'll get into a lot more as far as how these look, but the thing we need to remember right now is we have our upward P wave. That's where the heart first starts its impulse. It has a brief pause. Then we have a nice QRS. That should be 0.11 seconds or less. Now, in the pre-hospital arena, a lot of times we'll express it as less than 0.12 seconds. The reason is, if we think back, one of these little bitty boxes is 0.04. Two of these little bitty boxes is 0.08. Three of these little bitty boxes becomes 0.12. So it's very easy to measure, is it narrower than three boxes? So if we look from here to here, we'd say that yes, it's definitely narrower than three boxes, so therefore it's less than 0.12 seconds. We'll put it all together, and we've got a little video here to show you how the PR intervals actually work and how the impulse travels down through. We have our P wave. There's the impulse traveling from the SA node down to the AV junction, and then it's preparing to travel down through the ventricles. We'll have our QRS complex, whereas it starts to come down through the ventricles here, it makes them fire, and this QRS complex is as it starts to go back up. So here's the cycle as it runs through. So, okay, now we've talked about what a PQRS complex is and what each one of the waves represents. Let's get into the actual rules of ECG interpretation. Now, when we're trying to determine what a rhythm actually is based on a printout, one of the first things we need to determine is the rate, or the number of times the heart actually beats in a minute. The normal resting heart rate for an adult is somewhere between 60 and 100 beats per minute. Anything in excess of 100 beats per minute is considered to be tachycardic, or faster than usual. Anything lower or 60 beats per minute is considered to be bradycardic, or slower than the normal limits. So what we'll do is we'll try to count out the number of times or the number of complexes we see in each minute. Now, if the rhythm strip is fairly regular, we may count how many total complexes there are in a 6-second EKG printout and multiply that by 10 to get the minute count. However, if it's slightly irregular, we may want to count how many complexes there are in 10 seconds and multiply by 6, as that would give us a little bit more of an exact answer. That's one way of doing it. Count 6-second strip and say, okay, in 6 seconds, we've got 5 complexes, 50 beats a minute. Or if in 6 seconds we have 7 complexes, it's about 70 beats per minute. Now, from a clinical standpoint, the difference between, say, 65 and 70 beats per minute or 70 and 80 beats per minute is really very minimal. Another way we can interpret is we look at the space between the QRS complexes. Now, in order to do this, we have to look back at the EKG paper again. We know that the EKG paper is marked in very specific intervals. Now, as we do this, we need to find one of the QRS complexes where the R wave rests on one of the lines very well, such as right on this line here. And if we had an R wave here, we look for when the next R wave is. Now, if the next R wave is right on this line here, then we say, well, that's 300 beats a minute. If the first R wave is here and the next one is all the way out here, then it would be 150 beats a minute, or half as fast. If the first R wave is here and we get all the way down to here, then it's about 100 beats per minute. If the next R wave instead is all the way here, we'd say, okay, 75 beats per minute. If the first R wave starts out and the last one is all the way out here, that would be 60 beats per minute. If the first R wave is back at the beginning here and the next one is here, that's 50 beats per minute. If it's past this, we know it's under 50 beats a minute. Now this can be very handy, especially if you're trying to come up with a rate in a hurry, if you don't have a 6-second strip, if you've got very limited strip, a little limited printout, you can go through and you can say, okay, the first beat was right here, the next one was right here, so I can count down 300, 150, 100, 75. Okay, this rhythm is about 75 beats a minute. Now this may sound kind of contorted right now, but when you get into some strips, we'll work with it and we'll see. So let's see how we're going to compute rates. Well, a couple of options we have. We can start from here. This is the beginning of a strip, and we can say, okay, this from here would be 1 second, 2 seconds, 3 seconds, 4 seconds. This is about 5 seconds strip coming out to here. So if we counted this, we'd say there's 1, 2, 3, 4, 5, 6, 7. I've got 8 complexes there. So on a 6-second strip, 8 complexes, I'd say that's probably about 80 beats a minute. The other option I have is I can look and say, okay, this R wave is pretty close right here to the line. So if I say this is the first line and I start a countdown, 300, 150, 100, 75. Now I say it's just faster than 75, so I'd still say it's about 80 beats a minute. One thing you'll notice about the countdown method, because you have a 100 and a 60 in your countdown cycle, you can always determine, is it over 100, is it between 100 and 60, or is it less than 60? So if we were going to look at this strip, we'd say it's probably about 80 beats a minute. Does that sound right? Yeah, I can buy in on that. And when we correlate it back to the monitor, which we blacked out up here, the printout tells us, yes, that's right, it's about 80 beats a minute. Again, 2 ways to do it. We can count how many complexes in a 6-second strip, times 10 would be 80, or we can do a countdown. Again, if we went from this here, we'd say, okay, it's a little bit sooner than the 75 mark, so we'd call it 80. If we went from, let's see, this one right here, on this P wave, we could say, okay, 300, 150, 100, and it's a little bit before that, so again, about 80 beats a minute. So there's your countdown rate or your 6-second count, either way. Let's try it on another one. Now, this strip looks a little bit more regular. They're fairly close together. And if we're going to do it based on a 6-second strip, we have 1 second here, 2, 3, 4, 5, 6. So from this point here, if we're going to count all the way from here back to here, and say we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Okay, so that would be about 120 if we multiply by 10. Now let's look at it doing the countdown method. We start right on here. This is pretty close to the solid line. So we say this is that. This is where starting point will be right here. And we have 300, 150, 100. So we know that somewhere between 100 and 150 is the rhythm. So I'd say again about 120 would be correct. If we look a little further down the strip and we say, I want to confirm that. So I'm going to say this is my starting point. And I'm going to again do a 300, 150, 100. Well, let's see, it's between 100 and 150, about halfway. So again, it's around 120 beats a minute. That's what we come up with, two different methods, and when we look at the actual strip, 120 beats a minute. So determining the rate, there's a couple of ways you can do it depending on how much strip you have, how much time you have, and how regular the rhythm is in and of itself. The next thing you want to look at is how regular the rhythm is. And when we look at how regular the rhythm is it regular or is it irregular? Now, we want rhythms to typically be regular. That's normal. Normal rhythms should be regular. They should march out. Otherwise, anything that's an early or a premature beat can be clinically problematic. Sometimes you'll have irregular rhythms, and that can help us identify where the rhythm's coming from. Now, when we look at this rhythm, very simply, we can say, okay, first off, let's look at the rate. Well, the rate on this one, it's going to start from this one here, and we say from here it would be 300, 150, 100, 75, 60. Okay, this one is probably about 65 or so. And let's see, these two are much closer together. So if we look here, it's 300, 150, 100, and it's definitely well before the 75, so this would be about 90. This would be irregular. Just the fact that the gap between the R waves on this beat and, say, this beat or this beat are all different. So this would definitely be irregular, and it doesn't really even follow a pattern. So it would be not only irregular, but it would be irregularly irregular. Another way you can monitor this, and we don't have a way of putting scrap paper up here, but if you take a piece of scrap paper and set it right here, and actually marked on this scrap paper, I'm going to doodle a piece of scrap paper here for you, and you took that piece of scrap paper and you marked that piece right there and right there to correspond with those R waves, and then you slide that paper down and see if that gap is consistent on all the R to R complexes. Well, we can tell with the naked eye here, it's definitely not going to be consistent. So again, we'll call it irregularly irregular. Don't worry, I promise this gets easier. Alrighty, so now that we've discussed regularity and whether a rhythm is regular, irregular, or irregularly irregular, let's start looking at some of the different parts of the rhythm. We talked before about P waves. This is the start of the heartbeat. Normal rhythms should have P waves that are upright. Upright P waves in lead 2 indicate that the impulse is coming from the atria down toward the ventricles or moving toward the positive electrode at the left leg. Inverted P waves in lead 2 tend to indicate the rhythm is originating from the junction or somewhere below the atria and traveling backwards up through to the SA node. So we should have normal upright P waves. They should all look about the same. They should have a common shape, and that indicates that the rhythm isn't starting at the same place all the time. So we have the P waves. We've looked. Are they upright? Are they all the same? The next one is there a P wave for each and every QRS complex, and is there a QRS for every P wave? Think of the atria every time it fires, the ventricles should answer. We should always have a lub that goes with a dub. We should always have a dub to answer every lub. So the P to QRS ratio should be 1:1. Every time an impulse starts, it should be carried all the way through. The next thing we'll look at is how long it takes to carry all the way through. The PR interval. Now the PR interval is the distance from the start of the P wave to the beginning of the QRS complex. This represents the time from the start of the impulse coming out of the SA node until it causes the ventricles to fire. The normal value for this is less than 0.20 seconds, or less than 0.2 seconds, or less than 5 millimeters, or 5 little bitty boxes. If it's longer than 0.2 seconds, this would be a delay, and it could indicate a possible conduction problem. So if we look here, this would go from this point here over to this point here. So we'd say, okay, it's maybe 2 boxes, so it's about 0.08, maybe a little bit longer than that, maybe 0.10, but definitely well under the 0.20 or under the 5 small boxes. Once we've looked at the PR interval and we've determined what it is, then we'll look at the QRS complex. Now, as we said before, the QRS complex starts getting measured right here at the downward deflection of the Q wave, and it goes to the end of the S wave right here. So there's the width of our QRS complex. It's the depolarization or the firing of the ventricles. We say less than 0.12 seconds or 3 millimeters because, as I said before, it's easy to measure 0.04 seconds, 0.08, and 0.12, although technically you'll see in some books less than 0.11 seconds. That's harder to measure on this. If you're using a computer-generated ECG interpretation, you can get it, but to just read it off the strip, using 3 boxes is perfectly fine. Now, if the QRS complex is longer or wider or bizarre in appearance, this would be considered abnormal. Typically, anything that's originating from the sinus or the atrial junction will be a narrow complex. If it's a wide bizarre complex, that would indicate most likely something that's originating or starting in the ventricles, and we'll get further into that in section 2. So now we've talked about the different rules of interpretation. Let's start applying them to some strips. We've got an ECG strip here we can go through. The first thing we need to determine is what is the rate. Now again, there's 2 methods with which to determine that. We can figure out 6-second gap. If we start from here and we say, okay, this is 1 second, 2 seconds, 3 second, 4 second, 5 second, 6 second, cut off here, and we count how many QRSs are in it. 1, 2, there's 1 in here, although you don't see it. 3, 4, 5, 6, 7, and it looks like we'd be almost to the 8th one. Okay, so we'd say about 75 to 80 beats a minute. If we use the countdown method and we go from here, we say, okay, this is going to be the starting point, and we're going to say 300, 150, 100, and a little bit faster than 75, so we're saying roughly 80 beats a minute. So if we get it about 80 beats a minute, and when we look at the printout on the strip, it agrees with us. The next step we want to look at is how regular is the rhythm. So we look at the gaps between the 2 R to R waves here. They look pretty consistent. They look to all be about the same gap. I know there looks to be a little bit of artifact or something in here, but anyway, most of these seem to be fairly consistent. If we had a piece of scrap paper, or you could probably take and pause the video now and put a piece of scrap paper up to your monitor and mark these 2, and then again, look at the gap between the others on the strip. Seems to be pretty consistent intervals. Since the interval appears to be nice and consistent, we're going to say that this rhythm is regular. Now we need to start looking at the PR interval. And to get a little bit better on this, we're going to zoom in. So we have from the start of the P wave to the start of the QRS complex. Looks to me to be, about 4 little bitty boxes. Well, if we know each one of those little bitty boxes is 0.04, if there's 4 of them, that would be 0.16 seconds. Now we know 0.16 seconds is the PR interval, and is that normal? Yes, because it's less than 0.2 seconds. Now we'll look again at the QRS. As we go into the QRS, we see where it starts, we see where it ends, so it's about, looks like 2 little bitty boxes. So 2 little bitty boxes, if they're each 0.04 seconds, would give us 0.08 seconds. That 0.08 seconds, is that normal? Well, yes, because it's less than the 0.12 seconds. The next thing we want to look at for this rhythm, we'll zoom back out and let's look at the P's and QRS's. Does there appear to be a P for every QRS? Yes. Does there seem to be a QRS for every P wave? No lubs left dangling and no dubs happening on their own. So if there's a P for every QRS and a QRS for every P, that would be a 1-to-1 ratio. Now, as we look a little closer at all the P waves, do they all seem to be upright and about the same shape? Yes, all the P waves are upright and they all appear similar. So since we know what the rate is, it's between 60 and 100. We know the rhythm is regular. We know the PR interval is 0.16 seconds. The QRS width is 0.08. We have a 1-to-1 P to QRS ratio, and all the P waves appear similar. What are we going to call this rhythm? Well, we've applied the 5 rules, and this rhythm actually qualifies to be normal sinus rhythm. It fits all the rules to be a normal rhythm. Now, please understand this is the textbook definition of normal sinus. It can vary in appearance between different patients. You can have 10 patients that all have normal sinus rhythm and it look totally different. However, when we look at the 5 rules and we apply the 5 rules across the board, that lets us know if it's actually still normal sinus rhythm. So please apply less about what the tracing looks like and apply the rules in an objective manner, and you can categorize and qualify a rhythm to be whatever it's going to actually be determined to be. So as we begin to learn about interpreting tracings, it's imperative we correlate the waves to what we see as the function of the heart. When we see P waves, we know, okay, the atria appears to be functioning normally, or functioning abnormally, or functioning differently. We know that the QRS complex is letting us know something about how the ventricles are functioning. These tracings, although they can't necessarily say if the patient has a pulse or not, can tell us a lot about how the electrical impulses are being carried through the heart. And the skill of interpreting EKGs begins with learning the parts of the heart, applying these rules consistently to every tracing you evaluate, and that way you can determine the rhythms most consistently. I'd like to thank you for your attention through this. I know it's been long. Hopefully, as we go through section 2A through F, you'll be able to see a bunch more rhythms. You'll get a chance to apply these rules to a bunch of different rhythms and see the variations. So far, we've determined what normal sinus is, so I think we're off to a good start. Please, if you have any questions or comments, feel free to email me. My email is up there on the screen. Now we've got a little quiz for you here to check your knowledge. Thank you much.